Destination Medicine is a collaborative initiative of regional training hubs. With first-hand lessons learned from those who have gone before, this podcast is designed to assist and inspire anyone interested in pursuing a medical career in rural and regional Australia. Welcome to Destination Medicine. I'm Peter Letts. In 2004, before he was a GP and Associate Professor, Alam Yoosuff was working and studying at home in Sri Lanka when the horrendous Boxing Day earthquake and tsunami hit. Alam became involved with tsunami-related rehabilitation and community work, and by 2006, with a passion for preventative health, he came to Australia to do his Masters at UNSW in Public Health. Alam was offered a spot in the GP training program in Darwin, Ipswich and Finley. Knowing her husband's staunch preference for smaller towns, Alam's wife chose Finley, and the family love it. In the last 20 years, Alam has been pivotal in developing the Murrumbidgee single employment model of rural generalist training, a model now being rolled out across the country. What was a very small town with limited resources, Finley is now thriving with a primary care centre for the whole community. Nicole Goodman asks Alam what inspired him to come to Australia about 2 decades ago.
When people come to another country, migrate, we don't pick and choose. You get whatever is given to you, and then you need to work out how to establish yourself. I moved here when I was about 32, about 10 years behind many other graduates would be setting themselves up in their life. So I need to work around how to establish myself, how to improve my clinical practice, how to improve my interactions and connections, how to get through my exams. And those are the kind of stuff that I was more focused on. I've always had the feeling that, Finley gave me the opportunity, and Finley wanted me, and Finley took me as a preferred person. And I have a payback that I have to give back to the community. So hence I've been here for 18 years. Since 2008 onwards, I've been in Finley.
Very special, very special. How has your family adapted to regional life in Australia?
I moved with my wife, so we didn't have kids when we moved. And she liked Finley. And more importantly, the moment we came and settled, my practice manager and some of my practice nurses and few people around us in the town was pretty much similar, next to family. My practice manager was an adopted grandmother for my kids when they were born, and they used to come and entertain my wife. She wasn't working initially. So we got into this very close, knitted, connected community, and we became part of it. And even to date, my son's 14. For him, home is Finley. He studies in Shepparton, but he says Shepparton's the visiting home or mama's designer home to play with, but Finley is the home. Home is Finley.
Love that. Beautiful. What does a typical day look like for you then?
I start with my ward round in the local hospital. I'll come and see my inpatients in the hospital, go through a ward round. I have trainee doctors, registrars under me. I have an intern who works with me. So I might go with my colleagues, and my other junior doctors go for a ward round, have a chat, have a huddle with the nurses station about, what's happening with few patients, and, try to answer some of the curly questions. There might be administrative stuff. And once that's finished, then I go up to my GP practice. I call it my den. Go and sit there, and there'll be patients booked in from morning to lunchtime. I'll keep seeing them as regularly, as booked in. And that would be my normal consultation, runs till about 4 or 5 o'clock. And then there might be some patients I might have to see in the aged care, which is just all walking distance within, 200 meters. It's all within one premise. And then I go back home. 2 days out of 7 days, I am on call for the hospital. So I get called even after hours to come and see a few patients in the emergency department. Every second weekend or one weekend per month, I'm on call for the hospital, meaning I'll look after the inpatients, emergency department, and be on call for the hospital 24/7. One of the important part is quite often I would have a medical student with me. And the medical student will be running around with me the whole time, from the time I start my ward round till I finish at night, evenings. When I finish, the medical student will be hanging around me and, asking questions. And they have a separate room beside my room, so they'll be seeing their patients and calling me in to, see the patients after they've initially worked up. So that has been my normal context for almost 20 years now.
Alam, you've described your work as spanning from birth to aged care. Are you seeing that span of patient regularly?
Yeah. I mean, rural generalism, by definition, is there. You are the man for anything and everything, right? Now I know I looked after grandmothers, and now I'm looked after mothers, their kids. I'm sometimes looking after great-grandkids now. So that's the beauty of rural general practice. After being there for a while, you kind of know all their history.
How do you balance the diverse roles of GP, emergency physician, and aged care provider?
Yes, I think diversity is important to polish yourself up. I think teaching medical students, teaching junior doctors, as well as involved in administrative and advocacy roles are part and parcel of rural journalism. My perspective is that, if you're a rural journalist, you need to be a teacher. If you're a rural journalist, you need to be a policy advocate for rural health. If you are a rural journalist, you need to be a community change agent. So I don't look at it as doing multiple roles. I look at it as my role is a rural generalist, and rural generalist is by definition is multitude of roles.
Now, you do wear a number of hats and you've been involved in a number of organisations. While Director of Primary Healthcare for MLHD and Primary Director of the MRGTP, or Murrumbidgee Rural Generalist Training Pathway, what were you most proud of achieving?
That was an opportunity that I got due to current Chief Executive of Murrumbidgee Local Health District, Jill Ludford. I applied for a position, Director Primary Healthcare for Murrumbidgee Local Health District. That was the first such position in whole of New South Wales, Primary Healthcare Director in a hospital system. And as part of that role, I was involved in setting up the single employment model of rural generalist training. We call it Murrumbidgee Rural Generalist Training Pathway. Right? There's no such thing anymore now because it is single employment model rural generalist training pathway for the whole New South Wales right now. It was us, myself, including many in Murrumbidgee Local Health District. It was us who designed and ran the pilot. In Murrumbidgee Division, we recruited 5 GP registrars and started running the pilot for 3 years. And as of 2023, federal government and the state governments got together and said, this is our prototype rural generalist single employment model training, and they rolled over it, the same version, to the whole of New South Wales state. And not only the New South Wales state, it's in Victoria, Tasmania, Queensland, not far away from WA and Northern Territory too. I think all states will be up and running by January 2026. If I'm not mistaken. So I'm quite proud that, as a Murrumbidgee person, as a Murrumbidgee man, that we were able to demonstrate that a place-based solution such as Murrumbidgee Rural Generalist Training Pathway could make a significant difference for attracting people into rural generalism and being able to define a innovative model of recruitment and training in our region.
Well, I want to ask you about that because how has the single employer model impacted rural general practice training and recruitment?
It is early days if you look at a state level, but if you look at in Murrumbidgee's context, we have been able to recruit people where else otherwise we wouldn't have, number one. Number two, we have been able to work around medical students who are in rural clinical schools in our region, who are very interested in rural generalism, and, nurture them and work around them and work for their needs and tailor a training pathway that they can finish end to end within our region and become a consultant or clinicians who are rural generalists in our region. So my first registrar in Finley is a rural generalist obstetrician in Young now. My second registrar is a rural generalist obstetrician and anesthetist, both at this point in time. So they have commitment to our region. They have partners. They have bought houses. They are settled in our region. So this is not an investment for a year or two, or just not an investment for finishing training. This is a lifelong relationship and a contract to the region and the towns. And you wouldn't get that opportunity from a normal training pathway.
Alam, you've spoken beautifully about the positives of rural life, particularly in Finley, and the benefits. But I'm interested also in the challenges, some of the biggest challenges that you've faced in rural medicine, and how have you overcome them?
Rural medicine in Australia is full of challenges. Main significant issue I feel is that not a lot of metro cities understand what rural challenges are. And rural workforce issues, rural infrastructure issues, and support mechanisms such as transport, housing, and education are also impacting into what's happening around. The challenges that are faced is that lack of focus, lack of interest, lack of understanding what rural context is, lack of understanding how to improve the current workforce situation in the rural setting. So I've always had this concept that what works in Finley won't work anywhere else, and what works anywhere else won't work in Finley. We need to have a place-based solution. In Finley, we were able to work around, what is really essential for Finley and surround people and communities, and how do we make that essential stuff to build, and then based on that we'll work around what is nice to have, and then thereafter. So what we have worked around over the last 2 decades is a mechanism of defining what is a good solution for Finley and surrounding. And for that, we have the community-based organizations such as Rotary, Lions, Apex, CWA, and lots of other people who are involved, and aged care homes and other allied health providers, and the hospital system, which is run by Murrumbidgee Local Health District. We all have a common goal, meaning to be able to provide the best possible care for our people. And we all have a common objective, is that to make it work. And we have been able to gather all these influences which has been scattered all over in our town together towards one ultimate goal. And that has given us strength to be able to, build upon. Because when I first came in 2008, I was told this wasn't a place where we can actually employ a doctor because there isn't enough work. It's not viable. Now we have 4 full-time doctors. And when I came in, I was told that the hospital is about to shut down because there's no doctor, and it would be, declining its services to almost next to nothing, kind of, which has happened for other places around me, but our community hospital in Finley is one of the prototypes in whole of Murrumbidgee. People come here to see how we do things, and people come to us and to learn how to do things in other regions. So I think we are a flourishing and thriving hospital in Finley, and we are a flourishing and thriving primary care center. When I started, we had only 50 aged care homes. There was no dementia-specific beds. We have almost 90 aged care beds now with 17 dementia-specific beds, which is one of the largest aged care homes in the whole region, given the context of the population of about 2,500 around us. So the aged care only employs about 150, 200 people. It's the largest employer in the whole town. And Finley Medical Center, starting with over 700 or 800 patients, we've got about 6,000 active patients now in our books. And we train registrars, we teach medical students, we train practice nurses, and we have allied health services such as dietitian, asthma educator, diabetic educators. We have a psychiatrist who comes and visits us once a month from Melbourne. We have the geriatricians who come and visit us. We have established telehealth virtual care services with endocrinology, respiratory, and many other services. We have echocardiogram or cardiology services on site. So these are all possible because we were able to work around our priorities. The community is our main interest. Our people is our main interest, and let's work around it, make it work and make it happen. So we've all got together in a common theme to design and create a solution for us, and hopefully we'll be able to continue to build upon it and do better and better, and that's our goal.
Associate Professor Alam Yoosuff, a rural generalist based in Finley, New South Wales. This is Destination Medicine. Thanks for listening. Regional training hubs are supported by funding from the Australian Government under the Rural Health Multidisciplinary Training Program.